Hi everyone. So just a minute, about to start. I hope I'm there. Hi, good evening everyone. Sorry for the delay. There was some technical issue with my iPad, so that is why it got a bit delayed. Yeah. So good evening everyone. Let us start with this session. Okay. Let us start with this session of Unacademy. So before we start, let me tell you just about a very good, very important resource that will help you boost up your preparation. That is, please do use the question bank, and question bank is the most important resource, and we have a lot of batches for you. You can choose from any of them. Let us just start with this. Let us just start with this chapter. Okay. Which amongst them, this is a very important question. Which amongst them is not a muscle splitting incision? Which amongst them is not a muscle splitting incision? Which amongst them is not a muscle splitting incision? Okay. Which amongst them is not a muscle splitting incision? Come on. Good evening Pragya. Good evening. Yeah. Tell me which is not a muscle splitting incision. Well, gridiron is a muscle splitting incision. Okay, let me tell you the concept of muscle splitting versus muscle cutting incision. So if you talk about a muscle splitting incision, if this is the muscle, yeah, so the incision which is actually going to split this, divide this muscle, this is what is known as a muscle cutting incision. Rather, so if you cut it transversely, good evening everyone. So if you cut it transversely, perpendicular, that is going to create a muscle cutting incision. And if you cut it perpendicular, you can say along the length of its fiber. Suppose if you divide it along the length of its fiber, this will be a muscle splitting incision. So there's a difference between muscle splitting and muscle cutting incision. What is a muscle cutting incision? The division of muscle. Yeah. So the division of muscle is what is a muscle cutting incision. So you have to go perpendicular. And what is the muscle splitting? You have to go parallel. So if you are doing any surgery where you are dissecting it parallel to the muscle, that is what is a muscle cutting incision. Let us talk more important things. So what are all these incisions for? These are all the incisions that we make for the appendicectomy. Yes or no? So let us talk about this. And we recently had a question even on this also. So let us talk about this. Okay. So when we are talking about this muscle cutting versus muscle splitting, try to understand what are the incisions that we make for acute appendicitis. So we want to do appendicectomy. Nowadays, no one is doing open appendicectomy. Everyone is doing laparoscopic, but still, the questions can be asked. So what are the important relevant points? First thing that you have to understand is the umbilicus, and then you have to understand ASIS, anterior superior iliac spine. The next is we have a line which is known as the spino-umbilical line. So what is this line known as? This is a spino-umbilical line. So when we talk about the spino-umbilical line, medial 2/3 and lateral 1/3. So medial 2/3 and the lateral 1/3. This point is known as McBurney's point. This point is known as McBurney's point. So when we talk about the McBurney's point, what is so important here? So if we make incision perpendicular to this McBurney's point, students, this incision is known as A. What is this incision A known as? This is known as a gridiron. This is also known as McBurney's incision. So we have a gridiron, we have a McBurney's incision. Now, Now over the time, or this is also known as MacArthur's incision. MacArthur's incision. So over the time, there was some modification to this, and people said, let us be more cosmetically involved, because this is a scenario of acute appendicitis which is common in young. So in order to make it more, you can say, in order to make it more cosmetic, we planned incision like this. Now what is this? What is this? This is along the Langer's line. This is along the Langer's line. Now, do you know the Langer's line? They are the natural skin creases where you have better cosmesis. So this incision is incision number B. And what is this known as? This is known as Lanz incision. Lanz incision, or this is also known as Bikini crease incision. Yeah. So Bikini crease incision. So Bikini crease incision. This is what is known as. The next is, we might also go perpendicular to this. So if you are going perpendicular, this is what is known as incision number C. What is this incision C known as? The incision number C, better known as, yeah, anyone, this is known as Rocky Davis. Rocky Davis. Now remember, be it A, be it B, be it C. So A, B and C, they are all made perpendicular to the muscle or along the muscle fiber, So these are all muscle splitting incisions. So students, they are all muscle splitting incision. This is very important. So they are all muscle splitting. The next very important thing is, students, sometimes we may require to increase the incision length. Yeah. So if you want to increase the incision length, you may go for the lateral extension. So bachi, what is this? This is lateral extension of already made incision. So when you go for lateral extension towards the flank, this is known as Rutherford-Morrison incision. So Rutherford-Morrison is not an individual incision in a true sense. Yeah, it is actually extension of any incision towards the flank. Similarly, if you talk about the medial extension, any extension can be extended medially. So this is what is medial extension, and the medial extension of any incision. What is that known as? The medial extension is known as Fowler-Weir extension. This is known as Fowler-Weir extension. So when we are talking about Fowler-Weir extension or Rutherford-Morrison extension, what is so important? But say both these incisions, incision number E and incision number F. E and F, they both are muscle cutting incisions. They both are muscle cutting incisions. Are you getting this? So we have seen muscle splitting, and now we have muscle cutting in front of us. So muscle cutting. Now this year, it was an INI CT, they have asked which muscle is not divided. So I'm quickly going to ask you this question. Which muscle is not divided? Which muscle is not divided during appendicectomy? During appendicectomy. What is the answer, students? A, let us see, rectus abdominis. Rectus abdominis, point number 1. Then second is, we have transversus abdominis. The C is external oblique. Then we have internal oblique. Bachcho, both B and D are avoided. But rectus abdominis is never divided in this. Rectus is never ever divided. So we divide external oblique and internal oblique, both A and B. So A is a better answer than B. In some cases, when you are going for extension, you might require what? Division of transversus abdominis also. So A and A is never divided in this. So this is the answer. Let us go to this question. Which amongst them is not a muscle splitting incision? Yes, Lanz, true. it's a muscle splitting incision. Rocky Davis, yes, it's a muscle splitting incision. Gridiron is a muscle splitting incision. The answer is Rutherford Morrison. Students, you may get a question on laparoscopic appendicectomy also. So just a brief description. So this was open appendicectomy. So these are the incisions that we make for open appendicectomy. Now if you get a question on lap appendicectomy, because you know lot of questions are being asked nowadays on the minimal invasive surgery, and now no one is doing open appendicectomy. So if it is asked, the question will be, what is the port positioning? What port positioning we use for? What is the port positioning? Students, there are two types of port positioning. One is the ipsilateral port positioning. One is the ipsilateral port positioning, and one is the contralateral port positioning. Ipsilateral port positioning is a port positioning where the surgeon stands at one side and camera person is next to him. The contralateral port positioning is a port positioning where the camera person is in between, where the camera is in between, and you can say on the either side you have the ports. I'll show you. So when you talk about the port positionings, you don't have to mug up anything. The very first and the most important thing that you all have to understand, always define the target. So the first thing then that you require in every you can say surgery, you cannot mug up the port positioning for all the surgeries. So the very first thing that you have to define is the target. Where is the target? Now this is the target here. So the next thing is, where will be the surgeon, where will be the camera person, where will be the monitor and the trolley. So bache, the monitor, the camera, the monitor, the target and the surgeon, they are always standing in a straight line. Is that clear or no? So the monitor, the target and the surgeon is always going to be in a straight line. The next task is, we always use the, you can say, effort arm and the load arm as, you can say, the same. We don't use, we use the classical example, we use the classical example of a class 1 liver. What is class 1 liver? Whenever you are talking, but physics is present everywhere. What is the concept of physics that we use here? This is the fulcrum. Yeah. So laparoscopic surgery, the most important thing that we all have to understand is that the load arm and the effort arm, both should be what? Roughly equal. That means, how do you define this load arm and effort arm? This is the abdomen. Yeah. So the X length and the Y length, they should be equal. If it is not, then you will have overshooting and a lot of problems. So we know that the standard adult instruments, they are 36 centimeter. The bariatric ones are 45 centimeter. So we need to draw two arcs. What are the two arcs? One is drawn. The first arc is drawn. I'm just telling you, these are very important things. The students who come for training at my institute at LaproCare World, I actually tell them these things in depth and detail, but I'm telling to you people, if you are able to understand, it's well and good. You'll never have to mug up anything. So try to understand. I will make two arcs. What are these two arcs? Try to understand. The first arc is 18 centimeter from the target. The second arc is 24 centimeter from the target. So keep in mind, all the instruments should be in between this 18 to 24 centimeter window, because if they are not, you will never get a fine image and you will never be able to do the surgery properly. So whatever you do, you have to do in this window. Now the first port that we will make, will be the camera port. So generally, anywhere in this abdomen, the umbilicus will always fall in this window of 18 to 24 centimeter. If it is not, ignore it. You will make a 10 mm camera port. So this is your camera port or telescope port. So camera and a telescope port. Now bache, your telescope head is gone inside. Now you need to enter the at least two instruments or no? At least two instruments. Nowadays we are doing a single, we are doing it with, generally we are doing 3 ports. At my center I have recently started with a 2-port appendicectomy with the help of a striker milli irrigator. That's not that important for you. But now try to understand. When you are writing on a paper, can you see, you don't write like this, you don't write like this. When you're eating also, you always maintain an angle. What is this angle known as? This angle between the surface, the angle between the surface and this pen, or between instrument, or between your spoon and your plate. This is what is known as manipulation angle. If I increase the manipulation angle to 90 degree, I will not be able to operate. If I decrease the manipulation angle to 0 degree, I will not be able to operate. So what is the ideal manipulation angle? Manipulation angle is the angle between the two instruments, and it has to be 60 degree. So the next thing is the adequate manipulation angle. So in order to have a good manipulation angle, it should be 60 degree. It should be 60 degree. We make two instruments. We make two instrument ports, 5 mm, two instruments port, and remember they should be at least 5 to 7.5 centimeter apart. So you have made the instruments port, and now from them your instruments will go. So at least remember that whatever you are making, the angle between your operating instruments, the angle between your operating instrument should be 30 degree. Bache, this is the angle. Can you see this? This is the angle. Because if your angles are not 30 degree, bache, you will never be able to do the surgery. So ye ho gayi contralateral port positioning. Now someone says, like, if a female is operating, female might not be having that much broad arm span. So unke liye kya hota hai? There is a problem. There is a problem that they might not be able to expand that arms to an extent that they might be not be able to doing a contralateral. For them, we have the ipsilateral port positioning. Same thing students. This is the target. This is again the same thing, that 18 centimeter and 24 centimeter arc. The first thing that you draw is you make a 10 mm camera port. This is a 10 mm camera port. Now in this case you are making two 5 mm ports. Two 5 mm ports. They are all operating ports, and this is how you are going to operate from these ports. Always remember the drawback of ipsilateral is the manipulation angle. The manipulation angle is reduced. Is that clear or no? It is reduced to 30 degree. But what will happen if you make the ports too close? If you make the ports too close, try to understand, this is your camera. Now imagine this is your first instrument. Now imagine this is your third instrument. Won't your instruments be interacting with each other? You will not be able to do. So this is what is the ideal port positioning. So if you get a question on them, you should be able to understand if the instruments are on the same side. That is what is known as ipsilateral port positioning. This is what is ipsilateral port positioning. If you have the instruments on the either side of the telescope, that's a contralateral port positioning. Are these things clear or no? बच्चे ये कोई नहीं पढ़ाएगा आपको, and that too with free knowledge. No one is going to give you. But yes, I am telling you, I am teaching you, and take my words. One fine day, this will again will be in the exam. People who see my lecture, they say, sir, तो थोड़ा सा वो पढ़ा देते हैं, हाई-फाई पढ़ा देते हैं. But try to understand, there is nothing like hi-fi. We have all shifted. If you have to get appendicectomy, will you go for open or lap? You'll go for lap. When you are doing lap, when you are getting lap done, why you will not expect a question? It's so funny. Aata nahi hai. They have mugged up. That is why I give them a challenge. If you can mug this thing, never they'll be able to. Okay, let us talk about this. The next question. All except are indications for parathyroidectomy in symptomatic patients. In asymptomatic patients. Yeah. Tell me. All except are indications for parathyroidectomy in asymptomatic patients. Tell me. It's a very easy question. Come on, students, tell me. So parathyroidectomy, this is a very important topic, and let us revise this topic also. Few important points on this topic before we go for exam. Let us see. Someone more? Someone? Yes. But you should be attempting the question. The maximum that you will do is wrong, and don't refrain yourself from attempting question in my class. I'll not find it bad, because when I was at your level, I was a very, you can say, average student. I was not that intelligent. You people are far more intelligent than. So take my IQ as that only. Hai na? I'm not that intelligent student. Yeah. Okay. You know, intelligence plus hard work. This is equal to constant. So someone who is not intelligent, he can do more hard work. I can say I'm more hardworking. I'm not that intelligent. And remember, take my word, intelligent people are never hardworking. Yeah. Chalo, let us try to understand this question also. So I'll explain it to you. When we talk about the concept of hyperparathyroidism, HPT. What is HPT, students? Hyperparathyroidism. I hope all of you know that hyperparathyroidism is a condition where you have increased secretion of parathyroid because of any cause. Yeah. So increase parath hormone production. So increased parath hormone production may occur because of three reasons. What are the three reasons? It may occur because of abnormal gland. And if gland is abnormal, at least feedback would have taken the stand and stopped this hyperparathyroidism. So the gland is abnormal, and along with that, abnormal feedback inhibition. So abnormal gland and abnormal feedback inhibition, if it is there, we call it what? A primary hyperparathyroidism. This is what is known as primary hyperparathyroidism. So this is what is primary. Next is, let us try to understand the other things also. So primary hyperparathyroidism. If the hyperparathyroidism increase in parath hormone activity occurs because of one very interesting thing. What is that? Because of normal gland. So how will a normal gland secrete excess parath hormone? So normal gland with intact feedback inhibition. Then why is it possible? How is it possible? Yeah. In response to systemic hypocalcemia. So this is actually seen with what? This is actually seen with malabsorption. Or this may be secondary to CRF. And can you see, this is occurring secondary to a known cause, and that is why this is what is known as secondary hyperparathyroidism. Now when we talk about secondary hyperparathyroidism versus tertiary, what is that? You know, suppose if a patient has CKD for 10 years or 7 years, and after that the patient gets a transplant done. So for these 6, 7, 8 years, who was helping the body to maintain the calcium homeostasis? Answer is it was the parath hormones. So try to understand. A chronically stimulated parathyroid gland all of a sudden will not come back to its baseline activity. Even after feedback inhibition, it might not return back to its basic activity because of this long phase of chronic stimulation. And this is what is known as autonomous glands. So what is this? Increased parath hormone production by chronically stimulated gland undergoing autonomous activation. So when you talk about autonomous activation, this is what is known as a tertiary hyperparathyroidism. You know, this is just like a breakup. Yeah, this is just like a breakup. You know, in medical colleges, don't take me otherwise, I'm not sounding derogatory. So in medical colleges, we have the time bound affairs. Yeah, majority of the 80% or 90% of the affairs, they are broken down by the time of final year or maybe internship. Yeah, so this is like a chronically stimulated, you can say, lover who rejects or who is not able to accept that he has been betrayed. So for 6, 7, 8 years, the gland was helping the body to develop the calcium balance. But now once the patient gets a renal transplant done, body says, okay, you have been very we are highly obliged that you were helping us, but now we don't need your, you can say, support. So bache, the gland is just like a mad lover. And do you know a mad lover? You must have heard a dictum in Hindi, ishq mein dawa aur dua kuch kaam nahi aati. You must have heard. This is the true reality. And this is the same thing here. Tertiary hyperparathyroidism is mimicking a mad lover, and this is a surgical emergency. Is that clear or no? So tertiary hyperparathyroidism is a surgical emergency because this parathyroid gland is not under anyone's control and it can do anything. Is that clear or no? So this is what is tertiary hyperparathyroidism. Without wasting much of your time, I'll quickly go to the diagnosis part. How do you make the diagnosis? You know, in order to prove this, the first thing that I need to prove is increase in parathormone and along with increase in serum calcium. Now try to understand this. Is this alone sufficient to make a diagnosis? Increase in parathormone plus increase in what? Serum calcium? Never. Why? Because this same profile can be seen as a paraneoplastic syndrome of any malignancy. Why? You know, malignancy produce parathormone like peptide. So they can also produce the same effect. So how to differentiate and what is the hallmark? Is the serum chloride is to phosphate ratio. So serum chloride is to phosphate ratio, and that phosphate and chloride ratio is more than 34, and this is what is hallmark. So this is diagnostic. So always remember, in order to establish a diagnosis of hyperparathyroidism, not only do we require an elevated parathormone and serum calcium, we also require a serum chloride and the phosphate level. Are these points clear to everyone or no? The next thing is, let us quickly talk about the treatment. I'm not going to too much of depth. I'm just revising this topic with you so that before exams you all have the crystal clear and crisp concept. But the first line management that is done for majority of the cases is the medical management. However, this medical management is not useful at all. The treatment of choice is always a surgery. We'll see what surgery do we do later on, but before that, let us see the medical management. But we will stop the ongoing abuse on the bone, and that is why we add alendronate, zoledronate, so bisphosphonate. And what is this bisphosphonate going to do? This is going to decrease the osteoclast activity. So the osteoclast activity will be reduced with the help of these, you can say, bisphosphonates. Okay, it's acceptable. What about the calcimimetic agents? The calcimimetic agents. If you talk about calcimimetic agents, the name of one of that agent is cinacalcet. You must have heard of cinacalcet. When we talk about cinacalcet, which is very important, it's a calcium mimicking agent. Now try to understand, this is what is a gland. So this is parathyroid gland. You know that parathyroid gland has special receptors. And what are these receptors known as? These receptors are known as calcium ion sensing receptors, which you can say CASR. The moment there is increase in the serum calcium levels, there is stimulation of this receptor. And do you know this receptor is having a negative feedback? So this is going to go for a feedback inhibition. This is what is the beauty of this receptor. Yeah. So what we do, we cannot get calcium because already the calcium is elevated. Yeah. So what we do, we bring a calcium-like agent, and that calcium-like agent is going to fool the CASRs, and this is also going to initiate the process of feedback inhibition. So the important thing that you have to understand, that medical management is the treatment of choice only for one category, which is having intact gland as well as feedback inhibition. So secondary hyperparathyroidism is the only condition where you can expect this. Is that clear to everyone or no? When we are talking about the primary hyperparathyroidism and tertiary hyperparathyroidism, let us see all these things. So the treatment of choice is surgery. The first thing is, what are the indications of surgery? The first is failed medical management. Point number one. Second is, we have it for primary hyperparathyroidism, for tertiary hyperparathyroidism, and one very important thing that I am going to discuss with you is in asymptomatic patients. So there are asymptomatic patients of hyperparathyroidism also, where you can get this in asymptomatic patients. So what are those asymptomatic patients? When we talk about asymptomatic patients, with any of them, what are these any of them? The first is presence of nephrolithiasis. Patient is asymptomatic and the patient has developed nephrolithiasis. What does this mean? This means that it is a time to take a call for the patient. Otherwise, the kidneys will be lost and the patient will have to face the adverse effect. The second is GFR less than 60 ml per minute. What do you mean by GFR 60 ml per minute? This is a very important point. This means that the kidneys have developed a level 3 CRF and still you are not activated. This is an eye opener, that act, else you lose the patient. So nephrolithiasis, GFR less than 60 ml per minute. Third is any patient with serum calcium more than 1 gram 1 mg per dl, more than 1 mg per dl above baseline. So hypercalcemia, is a risk for pancreatitis. Fourth is any patient with nephrolithiasis, any patient with GFR, any patient with calcium more than 1 mg per dl, age of the patient less than 50 or 55 years. Why? These are young patients and they have a whole life in front of them. But say if you don't act in them, they will actually develop pathological fractures and lot of things. And the last is, bone undergo resorption. So you do a DEXA scan, you do a dual energy X-ray absorptiometry, and on DEXA scan you are going to see what the Z score or the T score. But say if the Z or the T score is less than minus 2.5 standard deviations, but say what are you waiting for? God has already taken a call for them. Is that clear to everyone or no? So but say this is an indication for surgery. I hope this is clear to everyone. So I think this was a question also. All except are the indications. Z score less than 2.5, yes. Nephrolithiasis, yes. GFR, it should have been less than 60 ml per minute. Is that clear? So what is the answer here? Answer is A is better option than D. Is this clear? Arko, I think you have answered D. Yeah, you have answered D. But say A is better answer than D in this case. Are these points clear to everyone or no? Yeah. Let us quickly discuss the management also, the treatment part, the surgery actually that we do for hyperparathyroidism. So bache, if it is a hyperparathyroidism due to malignancy, we go for radical excision plus minus neck dissection. If you have to do the neck dissection, you do a central neck dissection plus ipsilateral MRND. Yeah. Next is if you have it for hyperplasia. So suppose the patient has had hyperplasia. In case of hyperplasia, either you can go for partial parathyroidectomy. This is also known as 3.5 gland surgery. What is 3.5 gland surgery? You remove majority. Suppose these are the 4 parathyroids. you will remove all of them, leaving the most normal. So remove all except 50 milligram of most normal looking gland. Is that clear or no? Or you can go for total parathyroidectomy, and along with this parathyroidectomy, you will have to go for auto implantation. So plus auto implantation. Now where you have to do auto implantation, if I would have traumatized during the surgery for thyroid, and if the parathyroid was normal, I would have done the implantation in the sternocleidomastoid. But here the problem is, this is a pathological parathyroid, so I cannot go for sternocleidomastoid, because sternomastoid will have a recurrence. If it has a recurrence, that is graft-induced hyperparathyroidism, the second surgery at the level of neck will be very difficult, and you have a lot of vital structures which can be damaged. So auto implantation is done in non-dominant brachioradialis. So non-dominant brachioradialis. Is that clear or no? So there are a lot of students who mug up that we go for sternomastoid. Remember, in case of pathological parathyroid, sternomastoid is not the choice. Next is, the last is, we can have it because of adenoma. Now you know that adenoma can be of a single gland or it can be a multiple gland. So if it is a single gland, gone are the days when the preoperative confirmation was not there. So if it is a polyadenoma, I agree that you will go for BNE. What is BNE? Bilateral neck exploration. BNE stands for bilateral neck exploration. So you'll go for bilateral neck exploration, point number 1. Along with that, you will go for plus removal of abnormal looking glands. Is that clear or no? Students, if you talk about the single gland, what is that? You will go for, you'll go for minimal invasive open parathyroidectomy. So minimal invasive open parathyroidectomy. This is what is minimum invasive open. So you don't need to go for a classical McPhee or other types of incision. You'll directly make the 2 centimeter incision over the abnormal looking gland and take it out. So I hope this is clear to everyone. So we will quickly do one more important question. So I'll do a bit easy question for you. Okay, I'll discuss this question. Dysphagia lusoria. So is parathyroid clear to everyone, students? Is it clear to everyone? Okay, awesome. This is a very easy question. Very good, Rameshwar. Very good. When we talk about dysphagia lusoria, yeah. So dysphagia lusoria is a sequel of arteria lusoria. So dysphagia lusoria is a sequel of arteria lusoria. And what is a arteria lusoria? This is aberrant right subclavian artery. So aberrant right subclavian artery. This is what is. Let us try to understand this. What is the concept? Do you know, during the development, the right subclavian artery, if it is not originating, so here we have the right common carotid artery, we have the left common carotid artery, we have the left subclavian artery, and in certain cases the right common carotid is arising from the left trunk basically. So if it is arising like this, the right subclavian artery, now it has to go to the right side. How it can? So you have to understand that there is esophagus here. There is esophagus in the posterior mediastinum. You know that heart is in the middle mediastinum, and then you are not left with anything, and you have a vertebrae. So this is the lumbar vertebrae. This is the lumbar vertebrae, or these are the thoracic vertebrae. So what happens? The vessel tries to go in between these, in this paravertebral space, or you can say prevertebral space. Yeah, it tries to go like this. Now you have to understand that this is artery, and this artery is going to be pulsatile. Can you see the pulsations of artery? The pulsations of artery are going to cause good evening Sambarth. Yeah, so it is going to cause indentation on the posterior wall. Are you able to see? I'll make 2-3 arrows here. So this is going to cause compression. Yeah. So if you see the pulsations of the right subclavian, aberrant right subclavian, is going to cause the indentation on the posterior wall. And this is what is known as dysphagia lusoria. So the pulsations of right subclavian artery, yeah, on the posterior wall, this is what is very important, and this is going to first of all irritate the posterior wall, and hence a discordant, you can say, peristaltic movement, and it is also going to cause dysphagia. So this is going to result in dysphagia, and this dysphagia, because of this arterial lusoria, this is what is known as dysphagia lusoria. One more very important thing is that dysphagia lusoria, which is a sequel of arterial lusoria, is also associated with non-recurrent right laryngeal nerve. Is that clear? No? So I hope you know the importance of recurrent laryngeal nerve. Whenever we are doing the recurrent laryngeal nerve, whenever we are doing thyroidectomy, we are doing dissection of the Lore's triangle, or we are doing the dissection of the Biard's triangle. Now, can anyone tell me what is this Lore's triangle and Biard's triangle? Can anyone tell me? Yeah. So we have 2-3 triangles: Lore's triangle, Biard's triangle, Joul's triangle. So can anyone tell me? So since I am asking you, yeah, let us try to understand. Bache, I want to search. I'm asking you a question. I want to search recurrent laryngeal nerve. Is that clear? So I want to search recurrent laryngeal nerve. You know that if you want to search recurrent laryngeal nerve, a very important landmark is common carotid artery. And then what is going behind this? Can you tell me what is going behind this? This is inferior thyroid artery, and I hope you know this is how the gland is getting drained. And there are a lot of branches. One is coming to parathyroid like this. You know, inferior thyroid artery is the main supply of all the parathyroids, superior and inferior. Yeah. Always remember, the parathyroids will drain into their subsequent veins. Like superior will drain into superior thyroid vein, inferior will drain into inferior. But arterial supply is coming from inferior thyroid artery. And one very important structure is going like this. Yeah. What is this structure known as? This is known as recurrent laryngeal nerve. Now, bache, what is a Biard's triangle? So here we have Biard's triangle. What is that? We have common carotid artery. We have recurrent laryngeal inferior thyroid artery, and we have recurrent laryngeal nerve. This is what is known as Biard's triangle. Very good. But the most common nerve injury that is damaged is inferior thyroid recurrent laryngeal nerve and superior laryngeal nerve. That is external branch of superior laryngeal nerve. They are the two nerves which can be injured. In proportion to the external branch of superior laryngeal nerve, the recurrent laryngeal is more commonly injured. Let us try to understand. People say that it is the superior laryngeal nerve. It is recurrent laryngeal nerve which is more commonly injured. Let us see one more very important thing. What is Lore's triangle? What is Lore's triangle? Try to understand. If you expand a bit, this is the common carotid artery. This is the common carotid artery which is coming from the neck inlet. This is the neck inlet. What is present here, students? What is present here? Can you appreciate the trachea? Can you appreciate the trachea? So this is the trachea. And then we have inferior thyroid artery. Inferior thyroid artery. Inferior thyroid artery. The Lore's triangle is a more specific location. Lore's triangle. Okay. Joel's, no. We have a Joel's triangle also. Lore's triangle is the triangle. This is what is Lore's triangle. Bachche, the recurrent laryngeal is a content of this. Recurrent laryngeal is a content of this. Bachche, Joel's triangle is a triangle between the strap muscles when you retract them. The strap muscle, the external laryngeal nerve, and the thyroid. This is what is known as a Joel's triangle. So, bachche, Joel's triangle is for external branch of superior laryngeal nerve. BRs and Lore's are for the recurrent laryngeal nerve. Are they clear to you people or no? So, if you want to search for the recurrent laryngeal nerve, dissect from the thoracic inlet, basically at this level, go to that place and start tracing up. You'll always find. But say the right side is more medial, the right side is more lateral towards the carotid. The left side is more medial. Towards the gland. Is that clear? No, because on the right side it has to go a bit lateral over the recurrent laryngeal nerve where it has to arch. So these anatomical relations are very important so that you don't damage. Is that clear? So with this I finish the today's session. You can use the code Dr. Dixit to subscribe to my courses, or you can use the code Surgery Live also. There are two codes, Surgery Live and Dr. Dixit. I hope you enjoyed the session. Yeah. So we meet tomorrow at same time, and we'll discuss lot of other important things. Till then, bye bye. Yeah. So do give your feedbacks about the class, and do share the links of this class with your friends also. So till then, bye bye.